In the session this morning, I was outlining the need for the next generation gadolinium-based contrast agents. So you may ask why we need gadolinium-based contrast agents, because many of them are really a commodity now in imaging, and we use them day in, day out, and they're very, very safe. MRI continues to grow at about 3% per year, and maybe 30 to 50% of those MRI examinations will be using gadolinium-based contrast. For one reason or another. We use it in oncology, we use it in cardiac, we use it for inflammation, and it increases our diagnostic confidence, and it increases our sensitivity, particularly to small pathologies. So the use of gadolinium-based contrast agents has been a real success over the years, but there have been a few bumps on the road. The initial one was the finding of nephrogenic systemic fibrosis. This was back in 2006. That was the first link between the use of gadolinium-based contrast agents and the development of this condition in patients with severe renal failure. This was initially described in a dialysis and transplant center in the United States. But although the diagnosis was first made in about 1998, the link to the use of gadolinium-based contrast agents didn't really come about until 2006. And at that point, we realized that maybe there was something wrong here, and that maybe these patients, when we were giving them gadolinium-based contrast, it was hanging around in the body a bit longer, that biological processes were allowing some of that gadolinium to be deposited or retained in the body, and maybe this was causing the nephrogenic systemic fibrosis. Over the next few years, the use of the gadolinium-based contrast agents was restricted, and in Europe particularly, we classified the contrast agents into different types based upon their stability. So the linear chelates, which were the ones that were originally developed, we classified as being the highest risk for developing NSF, because in the studies and the meta-analyses we did, we found that virtually all the patients with NSF had had linear gadolinium-based contrast agents. And in fact, it's debatable as to whether any patients that were administered macrocyclic contrast agents, it's debatable as to whether any cases of NSF were ever truly discovered in these patients. So that was the first bump in the road. The next bump in the road was the finding of retained gadolinium in the basal ganglia and the dentate nuclei on T1 weighted MRI brain scans. The first paper was from Tomonori Kanda in Japan, and what he noticed was that patients who had received previous contrast enhanced MRI of the brain, when they next attended, further down the line on their 5th, 6th, 7th, 8th examination, he was noticing that there was this high signal in the dentate nuclei and the globus pallidus in the brain before he then gave the next dose of contrast. So he was thinking that this contrast must have been retained somehow in the brain from the previous examinations. And so that center, actually, they were using linear chelates. These patients had all had linear chelates, not macrocyclic chelates. So that sparked a lot of research, because it's a very easy study to do, to go back and look at, on your PACS system, all the patients who've had contrast-enhanced MRI of the brain and how many doses they've had, and whether you can see this phenomenon. And again, the meta-analysis of this work, the long and short of it is that if you've had exclusively macrocyclic contrast agents, we don't see deposition. But if you've had linear chelate gadolinium-based contrast agents, then we do see a high signal after about 5 or 6 doses, or maybe more than that. So the next question is, okay, we see this signal, but is that signal a sign of something that's bad for the patient? And luckily, the précis of that is that we can't see a signal that this is a bad thing for the patients. You would expect, from where this gadolinium is apparently being deposited, that you might get Parkinsonian symptoms, motor disorders and things, but we don't seem to see that. And large meta-analyses and large population-based studies don't see a deleterious signal. But the macrocyclic agents, we know that the amount of gadolinium there is much, much lower than it is for the linear agents. So the linear agents seem to deposit an awful lot more gadolinium there than the macrocyclic agents. And we also know from preclinical work that all these agents do deposit in bone, larger amounts than in the brain. But again, with no clinical sequelae that we know about. But again, this changed the paradigm in that the European Medical Agency decided that we had to therefore restrict the use of the linear chelate gadolinium-based contrast agents even further. And so most of the original agents were then taken off the market in the European Union, and we were left with the classic macrocyclic agents, which again we think are very safe. But it kind of reminds us that whatever we're doing in medicine, whatever drug we're using, and in radiology, the main drugs we use are contrast agents, that whatever we're doing, we should use the lowest dose possible. We should cause the least harm possible. And if we use a lower dose and we can get the same effect, then that's really what we should do. And we also now know from various research studies that when we give gadolinium-based contrast agents, we know that most of them exit the body very rapidly in the urine. The vast majority of it is excreted within the first day after administration. So it will end up in our drinking water. And it means that although we're only injecting it into patients that need it for scans, it may be that the population around hospitals in the waterways are actually unknowingly ingesting gadolinium-based contrast agents. There's now a drive to reduce the amount of gadolinium-based contrast agent that we use generally so that we put less into the environment, notwithstanding the effect that, most gadolinium is produced in China. It's a finite resource, and we want to preserve the resources for future generations. We don't want to use it all up. So if we can use a lower dose of contrast but get the same effect, then that's great. That's what these next generation contrasts are about. We're trying to find something that will give the same bang for your buck, but at a lower dose, make it more efficient.